everybody. Happy Saturday. My name is Suzanne Paulson. I'm the CEO and the founder of IECO, and this is a day where a dream comes true. For 18 years, I've been wanting to do something just like this, and I'm absolutely thrilled to bring you the first in a series of episodes all about dry eye and treatments for patients, education, and there's just been so many incredible advancements in the last even 5 years that it just was time to do something that was immediate, in front, and for you, direct from experts. And today we have a panel that's unlike any other. I am so honored and proud to be with them and for them to be with us. And it's just wait, I could do an episode on each one of them individually, probably multiple, because what they have done for the dry eye community has been phenomenal. I'm going to start with Dr. Laura Perriman. Introduce Dr. Laura Perriman. The most amazing ophthalmologist on the planet. And for a lifetime, all she's done is dedicate herself to dry eye, ocular surface diseases. She is a global leader, thought leader, and she has more enthusiasm than I do. And I thought I could never meet anybody like that. And she's compassionate and she's kind, and she can balance science with practical practice, clinical practice, implementation, and more, I think of even greater importance, compassion for patients each individually. So welcome, Laura. Thank you so much for being, Dr. Perriman, sorry. Oh, Dr. Perriman for being here. That was my first blunder of a live show. Okay, now second up, oh my goodness, we have Dr. Crystal Breimer. Crystal Breimer she's an optometrist practicing in North Carolina, another one who has spent her lifetime and decades relative to dry eye and the science of dry eye, but also, as all of these three are doing, they're very active in educating other doctors and getting other doctors on board. And with Dr. Perriman too, she does ophthalmology and optometry. Dr. Breimer started the Dry Eye Institute for Optometry, and she also attracts ophthalmologists. It's just, I can't say enough about her. So she's another one that her whole life is about dry eye. She has a special, well, you'll see it during the presentation. Just an amazing woman. I have Dr. Leslie Odell. She's on the panel too, an optometrist she's embarking on she's the clinical director of Medical Optometry America, it's a first of its kind that's just going to be amazing. She's been doing this for years too, decades, specializing in glaucoma, dry eye, and diabetic eye diseases. And another one, all of these people, they've written papers like over and over. So I'm just going to say, and TFOS, did I talk about TFOS? We have two, there's only 6 ambassadors in America for the United States. 2 of them are here, Dr. Perriman and Dr. Leslie Odell. So please welcome all 3. I'm going to kick this off. We have a lot to talk about. Now, you probably are saying, well, where's Dr. Now? So in this wonderful, beautiful day, we had some sad news this week that she had a loss, a family loss that was very close to her. So I'm not going to cry. She was so excited to be here, and what we're doing, we just thought the best thing for her, and she understandably needs to be with her family. So we are moving her beautiful presentation and all the lovely work she's done for 30 years to the November episode, which opens up this whole hour for causes and symptoms, which we need because, oh my God, overwhelming response from you. Thank you so much for helping us. You want to understand more about causes and symptoms. So that's what we're dedicating this whole hour to. I'm going to, with the next slide, if you can put it on the next slide, one of the things, so just a couple ground rules here, not ground rules. If you're unfamiliar with this platform, there is a chat box that's open. Go ahead and feel free to chat if you have questions throughout. There's also a Q&A box. We have some folks from IECO that are monitoring that, and we'll try to bring in whatever we can at the end for the Q&A. All righty then, let's get the game going. So when we're talking about causes of dry eye, what a huge topic of conversation, right? And we thought, well, especially now, look at us all staring at the screen. Digital device use has become one that is a huge topic of conversation. I wanted to kick it off there and hand it off to Dr. Odell for a conversation around digital devices and what that means relative to the ocular surface and dry eye. So let's go. Dr. Odell.
Well, thank you, Suzanne, and I really appreciate your energy and really, excitement for all things dry eye. So I know I speak for all of us, but thank you for, inviting us to be part of this. We're really excited to do something that's patient-facing for once, instead of educating our peers and the doctors that are treating the patients. It's really kind of fun to be able to connect with patients and learn, what their struggles are and what they want to learn about from experts like ourselves. So digital devices, again, like you had mentioned, in this day and age right now, we have been seeing a lot of increase in use. So patients are saying, that they might be logging 5 more hours, 1 to 5 more hours on digital devices than they were before March of 2020. And due to just the change in work style and working from home. I know, speaking for my own family, my children are both in a digital school right now. And so we are spending a lot of time behind the screens. But what people sometimes don't realize is how that impacts the ocular surface. And I hear, friends and neighbors kind of complain about their eyes burning or tired, and they're blaming it still a lot on the glare from the screen, or just, the fact that they're staring at the screen all day. And that is actually where the problem lies, is when you are looking at a screen, you blink about 50% less. So you are, in essence, staring longer than you would if you were reading a book, for example. And so what happens if you're blinking 50% less in your day? You're going to have dryness. Just, you're not supposed to be keeping your eye open twice as long each day. And so we're going to see things that are going to cause quicker evaporation of the tears. And then that leads to things like blurry vision. Sometimes people will have a later onset of blurred vision. They might start their day out great, behind the computer, for example, and then by 2 o'clock, they're just really having trouble seeing. They feel like they might, be having some of that blurred vision or eye strain. And it doesn't stop there. There's some really good studies that actually show that when you have dry eye disease and you are reading digitally, that your rates of reading are impacted. So that can translate even into worsening of your work productivity, which we don't want to see happen to anybody. Burning and fatigue are other big symptoms that you will have when you're having that dryness and evaporation of the tears. And so I think it's just really important. Some research that I actually was able to do, I was trying to find a population that was not as exposed to digital devices. And I came across the doctor. I live in Pennsylvania. And so we do have a large community of Amish, the Amish population in York County and in Pennsylvania. And so I connected with the doctor, Dr. Jonathan Andrews, in Lancaster County, Pennsylvania, a little over a year ago, and conducted some research where he was looking at the device use of his patients, predominantly Amish, and we were looking at the way our patients were interacting. And what we found was about 2 hours seemed to be a statistically significant difference on how the meibomian glands were performing for those patients. And so that was really interesting to me, and goes to show really if we're looking at patients that are spending a lot of time on digital devices, and that spans the lifetime of a person, I really want to get a baseline meibography reading so I kind of can see how that's changing over their lifetime, as well as looking for things like rapid tear breakup time. And I'm sure this panel feels the same. I'm sure, that you are seeing a lot of digital dry eye in your practices, but do you want to comment on that?
I would love to comment on that. Dr. Grammer, you go first, please.
Well, one thing I've noticed is that the symptomology of it is a little bit different. So I've had folks who they're tied into a web-based career, so they're on the device all the time, and they show up and they didn't have the years worth of dry eyes and the pain. It happened kind of all of a sudden. And then what was happening is they were losing their oil glands all this time by staring, not blinking enough, but it didn't create the same kind of symptoms that the typical aging process brings on when a patient is losing their oil glands. And so it kind of sneaks up on us as doctors. So it's really important as patients to make sure when you go to the eye doctor that they know how many hours you spend on the devices. And for me in my practice, it created a hard, fast rule that I'm always looking at their glands, no matter whether they have symptoms or they don't, because I know that it can be detrimental to those glands long before the symptoms start.
I love that. I totally agree with your clinical impressions. A couple additional things, I have found a significant uptick in the number of styes and chalazion that I deal with. And I think it's possibly a combination of the decreased blink frequency, the decreased micro expression of meibum, as well as masks. The masks are critically important, but tape it down with a gentle medical grade tape below this delicate skin area. Tape it down onto the cheek so that you don't get blow by back into your eyes. And that can help with symptom relief when you are out and about and needing to wear a mask for the safety of others, yourself and others.
Hey, we
And I think
were going to do a poll. We're
Great.
going to do a quick poll
Yeah,
on.
I was wondering if that just was going to pop up by itself, but it will be good just to see, you know, from the people who are watching, how many hours you're spending on digital devices. And when this poll was created, I want you to be thinking of not only about a desktop or a laptop, but, you know, be thinking about your iPhone or your smartphone. You know, those devices unfortunately now have, you know, ways to regulate how much screen time you have. And I would suggest you don't actually look at that. Sometimes I'm surprised how much time I'm spending on my phone. So would you say, you know, that 0 to 4 hours a day is where you are, mostly 4 to 8 hours, or are you in this beyond 8 hours? I am guilty of the latter. So I'm definitely beyond 8 hours and probably closer to 12. I don't know.
Yes.
It looks like, yeah, I can't see. One second.
And I agree with you, Dr. Breimer. I've actually included this in our questionnaires, our dry intake questionnaires as well, to try to help, number one, gain that data point in helping our patients, and number two, to raise awareness for our patients that it is a factor.
Absolutely.
And then as we're
for all of you with iPhones, and on Sunday morning, it sends you that notification of how many hours a day you've spent on average with your iPhone. That's a scary realization.
Yeah, I if I ever get to go down for a week, I'm like, oh, that was a good week.
I agree.
Well, I would say the majority of the data coming back here on the poll is that you've got the majority going at 8+ hours. And on that next slide, it cites those studies that you referenced, Dr. Odell, for the digital. But I think that given we only have an hour and we have a lot of things to talk about, I think you covered all this. Is there anything else in there that you wanted to
I didn't
touch
know
upon?
that. So go ahead, you can jump past that and go to the next. But basically, one other thing real quick, not only talking to your eye doctor about the number of devices you're using and the number of hours you're spending, but you know, also you can do yourself a service by employing that 20-20 rule that you may be familiar with, where you, after 20 minutes of using the computer, you're taking a 20-second break. You're doing actually some, you know, deliberate blinking, I would say, and even sometimes focusing at a distance. That can all be very beneficial.
Wonderful. That's great feedback. One of the other areas that we had a lot of questions before the event that the audience was hoping to have answered was they were related to surgery. So Dr. Perriman, do you mind walking us through some of what is that, the ocular surface condition and surgery, and what's that relationship? And
yes, I'd be happy to. Thank you for that question.
You bet.
Waiting for the slides to come up. So while we're waiting for the slides to come up, in general, ocular surgery is well known and well categorized to exacerbate dry eye. It's anywhere from the amount of dryness you have to what we call keratitis on the cornea, to even blepharitis and meibomian gland dysfunction. We know all these things get worse after cataract surgery. And we also know that dry eye is underdiagnosed and underappreciated prior to cataract surgery. Now, the prevalence of dry eye before LASIK and PRK ranges anywhere from 16 to 33%. And that's a younger demographic than the cataract patient. And it makes sense because if you're starting to have contact lens intolerance, it's like, oh gosh, I can't wait to get home to take these things out. I've tried 5 different lenses and my eyes are still bugging me. I'm just gonna go get refractive surgery and be done with it. Well, pay attention to those symptoms, because that could be an early warning sign for dry eye that really needs to be addressed before refractive surgery. And in the cataract surgery group, there's a very important study published by Bill Trattler. It was this awesome multi-center study, and they looked at all comers for cataract surgery. What they found was only 22% of those patients came in with a diagnosis of dry eye. And yet when those surgeons were mindful in looking for the evidence of dry eye, they diagnosed it 80% of the time. And so what that says to me is we need to do a better job as an eye care providing community in educating our patients, patient outreach, patient education, because the dry eye that's well controlled prior to surgery sets up an eye that is well prepared to receive surgery. And how I say this to patients is, don't be in such a rush to go to cataract surgery because you're about to put a wedding ring on the rest of your lifetime vision. So maybe we should date and buy some flowers and a cake and rent the hall. Like all those preparation things are important in the cataract surgery patient. So with that mindset, it's important to prepare. Now, if that didn't happen and you have a significant uptick in your dry eye, it's not too late, so don't worry. There's just more that needs to be done after surgery. On a physiologic level, and this is where my personal interests are, is in inflammation. We know that the anti-inflammatory factors and these special cells, oops, is there a cutout? Oh, here we go. And the goblet cells start to recover in the pre-op cataract patients after 6 weeks of using topical cyclosporin, specifically Restasis. There's this awesome paper out of Houston. So that's probably the ideal time to start medications. Ideally, dry eye treatment started years and decades before that, when the contact lens intolerance started to happen, because what we know is that dry eye that is ignored gets progressively worse. So I'm always congratulating my patients that are coming in earlier part of the game rather than late stage dry, because the amount of work that we have to do as a team, myself and the patient, is much harder. But when you catch that in the earlier stages, you set that patient up for success and the quality of their lifetime vision. And here's the thing that Scott Schachter in Pismo Beach, California taught us, is that dry eye is a vision-based disease. And I really do believe that it's quality of vision. It's not just those black and white little numbers, blink, blink, oh, I can kind of see them. It's glare, halos, ocular fatigue, all of these things that come into the symptomatology of our wonderful dry eye patients. And as your physicians, as your doctors, we need to be listening for these types of symptoms and offering you help much earlier in the game.
Super. Do you want to, with your slides, do you want to keep going there?
I think there's only like 4. If you, maybe click a few forward. So that's the overall philosophy and mindset is, oh, here we go. The lacrimal functional unit. This is so cool. Maybe Suzanne, you can chat in the box how many minutes I have, and I'll make sure I get done in time. This is a diagram of how tears are made and sustained. So the cornea is constantly sampling the quality of the tears and sending signals back to the brain. The brain then sends a command to the lacrimal gland, to your oil glands, and to your goblet cells. Hey, I need you to put out a little bit more. Well, in the dry eye patient, that system is offline. And in the surgical situation where we've actually cut corneal nerves, whether it's from cataract surgery or refractive surgery, that rheostat that's constantly sampling the quality is temporarily offline while we're waiting for those nerves to heal and reconnect. The well-controlled dry eye patient has a much higher chance of getting a very good nerve recovery process in their post-op course. So this is how the system is designed to work. This is what we're, as clinicians, we're constantly trying to restore, and neurosensory compromise is part of the TFOS-DUES-2 definition of dry eye disease. So that's one of the reasons why we pay so much attention to the neurobiology of this amazing system. And if you just think of the rheostat on the wall in your room, that's essentially what this is doing. Constantly sampling the quality of the tears or the temperature in the room, sending the signals back to the, the central heating, cooling, whatever it is. In Seattle, it's quite great. So in our case, it's heating. I don't know what part of the country you're in, but it's a constant check and balance, constant feedback system that we're trying to restore. Next slide, please. Trying to restore homeostasis. Looks like the background didn't get changed. So, and that's okay, because those are a lot of big words on the other side, so don't worry about those. But look at these pictures. That left side of pictures is confocal microscopic images of the cornea, right? And this is a dry eye patient. Those lines in the upper left, those are the corneal nerves, and they're abnormal. The middle one on the left, that's the epithelial cell tight junction. So the epithelial cells are red rover, strong, like keeping out the invaders. But with dry eye, their population suffers, and that allows access of allergens, bacteria, all these other things. So we need a strong fence to keep the wolves out, so to speak. And then that bottom line is deeper in the cornea, where the keratocytes are that make the strength of your cornea. On the right side, this is after 6 months of treatment with Restasis. Now, this patient that has on the right, that has had this awesome recovery in their corneal nerve pattern, this fourfold improvement in their epithelial cell density, and this quieting of all this inflammation activation in the deeper layers of the cornea, they may or may not be feeling better yet. But as a clinician, I know that I'm getting these benefits. Now, this one on the right is going to be much more successful. That's what I'm looking for, much more successful in healing after any type of surgical procedure. Next slide. There's one more there. And it's the most heavily innervated tissue in the body. And so we have to make a tiny entry wound in order to do the cataract surgery, and you don't know where the trunks are. And this can create a temporary, what we call neurogenic dry eye, because the nerves aren't able to sense, and also they're not able to deliver all as well messages from the brain. The corneal nerves not only sense, but they send all as well messages to the ocular surface to calm down any mischief, sort of like Barry Manilow music outside of a 7-Eleven, calms everything down, right? Okay, next slide. There we go. And this is just a quick graphic from a paper I published this spring, and I hope it's of good use to the nerds in the crowd that want to read more. This system is designed to handle an insult, whether it's environmental or surgical, and quickly readjust to baseline. We call this homeostatic control. Activation of inflammation, but then back to control. It's 1 foot on the gas, 1 foot on the brake, and like a bad taxi ride in New York City. But on the right, with dry eye, that return to baseline doesn't happen, and you end up in this chronic vicious circle of inflammation and injury and reactivation of inflammation, which is why we're so keen as clinicians to stop that inflammation driver of dry eye disease. Next slide, please. Okay, I think we covered, preparing for the wedding day. Next slide. And then pre-op or post-op, we're constantly, as the patient and with your clinician, you start with a treatment plan, figure out what works, what could work a little better, what's still missing, and readjust. It's a process in getting dry under control, whether it's pre-operative, post-operative, or in a much younger stage of someone's life. It's a process. And I think that mindset for patients is very, very helpful. There is no one silver bullet. There's not one thing I can do to fix your dry eye. There's multiple things I do. It's a multifactorial disease that needs a lot of tools to address it. And that's that constant check, balance, reassessing process. And here's the super good news. The options that we have for treating our dry eye patients is expanding exponentially. The options that you can do at home to really enhance that awesome treatment plan that you and your doctor came up with together is expanding. There's multiple outstanding at-home products. And just a shout out to Suzanne, because she's got a lot of them. Next slide, please.
Yes, I have. Next.
Yeah, that's it. There's no magic bullet. With dry eye, it's all hands on deck. Patients get into the mindset of process. It's not linear, it's process, and team up with your doctor. We're on your side. That's it for mine.
Awesome. Thank you so much, Dr. Perriman. And on the next slide, if you could, we're gonna. There's so many different areas that we can talk about. So we're diving into the other one. We had a lot of questions, and can you get the next slide up, please? physical contributors to dry eye, there's a lot of them. So poor diet and nutrition was a huge one we had a lot of questions about. So if you can go to the next slide, please. We're going to have Dr. Breimer talk to us a bit about what diet has to do with dry eye and how that can change the quality of your life. Dr. Breimer?
Yes, ma'am. So many times, so many times as a patient, you come into an office and you see the doctor and you want them to do something, and there's no blame there. I want your doctor to do something for you too, and we should, but that's not the end of it. It's what happens when you go back home that has a true and real and just a huge impact on your outcome. And it starts with what you're putting into your body, and that's your diet. It's not just hydration. It's not just drinking water. It's the food you eat. So on the next slide, what you're going to see is the background of it. Guys, go to the next slide. There we go. So on this slide, you see kind of the chemical reaction that's happening behind the scenes when we eat negative foods versus positive foods. So enzymes found in foods can boost serotonin levels. That means that foods have an impact on your mental outlook, on your mental state. So nutrition adds to anxiety and depression, and anxiety and depression add to dry eyes. In addition to that, I'll share just a couple little studies. There's a study that looked at among 10,000 males, and if they were in the top third of sugar intake, which was 67 grams or 2 Cokes, if they were in that top third, they had a 23% increased risk of anxiety and depression. There was another study that looked at 22,000 students in Spain, and when they adhered to the Mediterranean lifestyle over the course of like 18 years, they had a 50% reduction in their risk of depression. And then a third one I'll share was a study that looked at patients who were already moderate to severely clinically depressed and being treated, and they had a control group versus a group that changed their diet. And when they changed their diet, there was a 32% remission rate versus the 8% in the control group. So here's my point. Foods make a huge impact, not just in linking it to dry eye, but indirectly in linking it to anxiety, depression, and inflammation. And if you make that slide a little bit bigger, you don't have to see me, you'll see the details here. So sugar related to anxiety and depression, enzymes relating to serotonin levels. And not only that, but it influences the gut health. And when there's more inflammation and more bacteria in the gut, now we've got another contributor to anxiety. So this is a big deal. It's not just about being in shape. It's about the eyes being an end organ. And it's everything that happens in the middle between in your core of your body that is actually being shown and influencing that outcome on the eyes. So keep that in mind. Next, you're going to see foods that actually cause inflammation. So here we've got some of the same theme here: sugar, high fructose corn syrup, trans fats. And this is something they do. They add hydrogen so that it'll give them more stability. Vegetable and seed oils, there's very little fiber in there. So it uses that gut bacteria, increases obesity and inflammation. Refined carbohydrates, very little fiber again. And so same scenario. And then excessive alcohol, processed meat. All of these foods lead to inflammation. And inflammation is the core at a lot of our systemic diseases right now, our biggest killers, the diabetes, the heart disease, the obesity, but also linking it to the anxiety and the depression. And when we think about that and how it relates to dry eye, there's actually 28 studies that link depression and anxiety to dry eye. So all of this is interconnected, and it starts with what you put into your body. So what does this really look like in your diet? On the next slide, we'll see what it translates to. It translates to all the good stuff, right? It's the white bread, the French fries, the soda, the red meat, Wine's not up there, but it's there. The margarine. So really be mindful of this. And in one of the later episodes, we'll walk through eat better about it. But I'm a big at this with my patients, and I give them a 119-page patient education book, and a lot of it is what you put into your body and how you treat your body at home. And next slide, we'll see foods that are anti-inflammatory foods. Look at that next slide, guys. There we go. So anti-inflammatory foods. I got to give you some little piece of what you can do in a positive way. Olive oil. I only cook with olive oil now. Eat those dark leafy green vegetables. I add in tomatoes whenever possible. I'm constantly now grabbing a handful of almonds, whereas before it would have probably been chocolate chips. And walnuts have a very high level of omega-3. So there's a ton of systemic benefits with omega-3, including anxiety, depression relief. Fatty fish, salmon. That's one of the most fatty fish that you can lean towards. And then fruits. If you're not a huge fruit fan, but you like frozen treats, throw them in the freezer. And then next slide. It's just us. And guys, what have you seen in your practices as far as diet and patients' lifestyles and how it's influencing their outcomes?
I wholeheartedly agree with everything you said. Thank you so much for pointing out. That's just, I call that focus on the diet phenomenon, pharmacy, F-A-R-M, what you put in the pie hole matters, right? So we can, and it's the cheapest thing you can do in dry eye because you got to eat anyway. So might as well pick the right things. We recommend all of our patients do a Whole30 diet. It's an awesome way of figuring out your food frenemies, figuring out what you thrive on, what you don't, and it follows that anti-inflammatory profile that you beautifully described. So yes, I've seen just simple diet measures make lovely, tremendous differences in our patients, particularly those that may have autoimmune disease. So I find that a nice anti-inflammatory diet and the supplementation of a quality omega fatty acid, I have my personal favorites based on science, but that combination is foundational for the rest of what we do in addressing dry eye for our patients.
Super. Dr. O'Dell, any comments on that one?
Yeah, I also just kind of review with patients their water intake, because much like we are what we eat, you have to also, be drinking a lot of water. Since yes, cheers. So that's another thing, and it's actually sometimes interesting to see, what people tell you. I've had patients tell me, I get my water from cutting my grape juice in half with water, and that's what they drink all day, or, soda or coffee. So I think it's really important to talk about hydration as well, but definitely diet is a big part of where we can modify. So great points.
Super. Great. So on the next slide, we're going to move along. I can't believe we're already this far into it, but we have more physical contributors to dry eye. Can you show the next slide, please? And it has to relate to aging and hormonal changes, medications. These are some more questions that people had asked. And we're going to do a quick poll. Can you pull up the aging poll? And we're going to find out where our audience is. And while we're getting that information, do you guys want, it's going to be kind of an open discussion for folks, for the panel, kind of what your thoughts are. Obviously, aging being a huge one, hormonal changes, medications, and this the CCH too. If you can all just discuss some of those contributors, that would be real beneficial for the audience. Can you put that other slide back?
I'll go
please,
first. Yeah,
great.
This is such an important topic. I just participated in a think tank around vision and gender disparities, particularly when it comes to health research, state of knowledge, and research and policy. And we really looked deeply into the role of hormones over the course of a woman's life across a variety of disease states: dry eye, diabetic retinopathy, neuro-ophthalmic diseases, pregnancy, etc. And it's a very much a fluid and dynamic situation, particularly for females. So I think that role and awareness around aging and hormone changes is really important. Now the impulse would be like, oh, well, I've gone through menopause. I just need to replace what I'm no longer missing. But when you replace with estrogen and progesterone, your risk of dry eye disease actually goes up by 70%. Dr. Sullivan out of Harvard did that research. So it's not necessarily the estrogen and progesterone that protects you. It's actually the testosterone, which is probably why we see dry eye disease in women of reproductive years who are using oral contraceptives, because you have this ovarian suppression and your testosterone level drops, and that you lose that protective mechanism. Men's testosterone level, testosterone, I don't know, is that even a word? That happens more in the 50 to 60-year-old demographic, and that tends to explain why they're 20, 30 years behind the bell curve of women when it comes to the onset and prevalence of dry eye disease, in part.
Interesting. Okay, great. So what about medications? The role of
Important
medications.
topic, right?
Yeah.
Yeah.
I'll leave that to my
It's a-
colleagues.
Yeah, it's a huge area, and especially a lot of our patients that come to us with severe dry eyes, like you said, Dr. Perriman, they're immunocompromised already, potentially. You know, they may have fibromyalgia or some other autoimmune disease, and a lot of them have diabetes, they have thyroid issues, all of this. And so they're coming in with a laundry list of medications, and it makes it very difficult because dry eye is a side effect for many of them. And what I do is, instead of immediately coordinating with the primary care and trying to switch those up, I really try to look at what are the underlying issues that we can control before we go and change medications. But I also want them to go back in their history and look and see, are there symptoms that are brand new that could have been brought on by one specific medication? And if we can put our finger on it, that's a different story. We'll look for an alternative. But I think the first step is awareness.
Yes,
I would
and
definitely
prior medication exposures, right? Oh, pardon me, Dr. Adele, sorry, I didn't mean to interrupt.
Oh, that's okay.
Go ahead.
I was just going to say I've had some success when patients could change a medication, whether it was maybe like a diuretic or a blood pressure medicine. They could make a change because they could figure that they were, having a worsening of symptoms when a certain medication was started, and then changing that really helped me gain better control of their dry eye disease, because it was, they switched to something that was less drying for them. But it's definitely a big problem. I sometimes find that patients, maybe not so much the dry eye patients, but still there's quite a bit of people that disassociate their eye from the rest of their body. And so they think, well, why do you need to know what else is going on with me if I'm here for my eye exam? But medications are going through our blood vessels, which are part of your eyes. And, all of these medications can have an effect on your eye health and vision. And it's really important for us to review all of your medicines and even your, reasons for taking those medications. A lot of the systemic diseases that you're being medicated for can also be contributing to your dry eye symptoms.
And prior medical exposures are important too, right? So if we ask on all of our patients, have you ever taken Accutane for cystic acne? That's a really important prior medical exposure to tease out. And also chemotherapy. It's surprising the number of cancer survivors that walk into our dry eye clinics, and I'm so happy for the approval, survivability, and all of our advances. The chemo does have a role in meibomian gland dropout, damage to the lacrimal gland, and so that prior medical exposure is another important piece to your doctor.
And also over-the-counter medicines. We're focusing more on
Yes.
Pharmaceuticals, but one thing that I can help a patient with immediately is acknowledging, are they taking an antihistamine? And if they are, we try to look for alternatives. I do allergy testing in the office, and we try to find out, is there a way to do avoidance? And if not, can we do an immunotherapy where we're building their tolerance with sublingual treatments instead of having them dry out with antihistamines? The other thing I'll do is just make sure that they're not automatically taking it every single day and forgot if they have symptoms or not at this point, because they've been doing it for so long. And if they can get by with a nasal spray instead of an oral antihistamine, that's going to be less drying as well.
Mm-hmm. Yep. And topical eye drops. I do the same thing. I hit it from above and below, because the tear drainage system is a 2-lane highway from an immunologic and an allergy point of view. So I like to treat with a topical medicated eye drop, ideally prescription, because those tend to have better itch reduction scores than over-the-counter versions, with the exception of the recently over-the-counter moved Pataday, which I'm very pleased to see. But I agree with you, the oral antihistamines, that's a biggie. And it's partly because the symptoms of dry eye and allergy can overlap and people confuse the two. So definitely talk about it with your doctor, because if there's no signs of allergy, we got to get rid of that medication that's contributing to the problem.
Mm-hmm. And sleeping pills too.
Yes.
Mm-hmm.
Women in the perimenopausal demographic tend to use Benadryl as a sleep aid. You got to stop, because that's definitely contributing to dry eye.
We're gonna expand on allergies here at the end too. We're gonna move it to the next topic, which is one of the another big area and cause of dry eye, which is contributors of night. And so, if you can show the next slide, there are many in this area, but poor sleep, lid closure issues, sleep apnea, just to name a few. And we're going to dive into poor sleep. And before we do that, just a quick nighttime pulse slide. And by the way, on the aging, just so for reference, it looks like the majority of folks out there are over 60. But for nighttime, this I think is something that's really interesting. If you can put up the nighttime poll, please. We're going to be looking at how many people, how many hours of sleep do you get, and then also looking at how your eyes feel when you wake up, and whether or not you do have sleep apnea and wearing a CPAP. So if you can get that poll up, please, and then move it along.
And Suzanne, is that how many hours of Suzanne, is that how many hours of continuous sleep? Because that's where I think I'm starting to fall into the problem of continuous sleep.
That's a great question.
Continuous
sleep. So it would be continuous sleep. And if so hopefully everybody sees out there that poll. And then you guys, can you move to the correlation of sleep disorders and dry eye disease? And Dr. Breimer, do you want to share a little bit on that to kick it off with how that impacts the dry eye quality of sleep?
Definitely. And this one is just looking at a study that was retrospective. It was 44,000 patients, and they simply did an analysis to say, of these patients with sleep disorders, is there a correlation with dry eye? And there absolutely was. There was a higher percentage of patients that had sleep disorders and dry eye versus dry eye in patients without sleep disorders. And on the next slide, we'll kind of look at how does this play in. And this is thinking of it as a chicken and the egg scenario. Sleep physiologically can influence our tear secretion and tear film. In the study, what they found was that there was lower Schirmer score, which just meant tear production, and that the tears broke up quicker. They evaporated more quickly, which meant there was also not only less volume, but less oil content in their tears. So yes, physiologically it can have an impact, but I think in addition to that, it's absolutely creating more anxiety and depression. And we talked about this earlier, the anxiety and depression then lead to additional dry eye. And on the next slide, you'll see kind of this circle where it's just cumulative. It's a big snowball. You sleep worse, you're in a worse mood, you've got more anxiety, more depression, you've got more dry eye, not just from the initial lack of sleep, but also the anxiety and the depression that's in there. And I've seen this in patients' lives where we're doing great with their control. Suddenly, the stress of the world gets them and something falls apart and their outcomes suffer. And I've seen the opposite be true when, we're struggling, and then all of a sudden life kind of gets pulled together for them and their eyes are better. But this is a big part of that, because life affects your sleep, and then sleep is affecting your body. In a closed eye state, there is no dry eye. So when you have a night where your eyes are constantly open, then all of a sudden you're waking up more fatigued and your defenses are down from the beginning, and especially if there's a poor lid closure during the night. And we'll talk about that in a minute. Then look at this next slide. This is one study that I absolutely took to heart, and so I want to share it with you. It's talking about, one, just common sense. We've got to have the sleep and the nutrition so our body can recover. I remember years ago I started getting gray hair, and they said, how much are you sleeping? I was like, what does that have to do with this? But it was, when I go through periods of high stress and I don't sleep as well, your body doesn't have the chance to recover. And here you are trying to pour out into everyone else, and you've got to give yourself the ammunition to do so. So in this study, they looked at 4 different groups. They divided people up and they said, okay, group number 1, you guys cannot go to sleep for 3 days. Group number 2, 4 hours a night. Group number 3, 6 hours a night. And group number 4, 8 hours a night. Long and short, the 8-hour group had no decrease in their performance, their motor skills, their cognitive ability, nothing. They performed exactly as they should have. Group 3 and group 4 continued to decline each day. So if we look at the next slide, and you see that this is cumulative, and this is something that I was not acknowledging. So yes, the 4-hour group were the worst performers, but the 6 was just about as bad as the 4. So here, so many times we keep pushing and pushing, and we say, well, we're getting 6 hours. That's okay. That's good. At least I got my 6 hours. 6 hours is not good. It's not enough. And go to the next slide. So in the ones that had 6 hours of sleep, more than 25% were falling asleep after 1 week. And after 2 weeks, it was as if they had stayed up 2 days straight. That's how their performance, it was equal to the performance of the group that stayed up 2 days straight. And look at the next slide. So why are we not realizing this? You know, we're not, because we have very well-lit offices and a lot of continual stress and stimulation throughout the day. We're talking to people, we've got caffeine, we've got stress, we've got deadlines, all these things. I notice in my practice, I feel like I'm good, I'm on top of it all day long. And then when that last patient walks out of the door, I'm thinking, I can't remember what I was thinking. I can't remember what I was going to say. And it's like, how am I a different person now that I was 20 minutes ago? And it's because all those other things were keeping me going. And then keep going, guys. So here's the kicker for me. Participants did a self-assessment, and the ones that were getting 6 hours of sleep, they thought their performance was fine after a couple days. They thought that they got back up to normal and they were doing just great. And then in reality, when they did their little scores and their tests for their motor skills and their cognitive ability, they were actually getting worse every single day. So this was a wake-up call to me of how big of an influence it has. Next slide, guys.
Super. Thank you so much, Dr. Bremer. Oh, go ahead. Sorry. Yeah, dive on in. There's more, but wait, there's more about nighttime. It's like it just goes on. So these are some of the other questions that we had, but certainly it's like people like myself, lagophthalmists, you know, it's hard first to get all the hours and then to have this issue of lagophthalmists. So maybe Dr. O'Dell, all of you can share a little bit about these different things like compromised lid seal, lagophthalmitis, what they mean to the patient relative to dry eye and CPAP use. Thanks so much. Who wants to kick it off? Dr. O'Dell? Oh, your audio.
I'll fill in while she's getting her tech going. Oh, there she goes. Did you get it? Oh, she's got a technical thing. I'll jump in to give her some time. Awesome presentation about the role of sleep apnea and dry eye. Great job on that. One of the things I ask in all my patients is, how do your eyes feel when you get up in the morning? And if it's like, oh, you know, you have to put a drop in to get going, or I have to wake up at 3 and put drops in, that is a clear red flag, a clear signal that there's a problem with how well your eyelids protect your cornea while you're sleeping. Because it's true, not only does your tear input rate suffer, and not only is that impacted by the amount of sleep you get, but the people that are mouth breathers and not nose breathers also have a further reduction in their nighttime tear production. So I ask those questions too. Are you a mouth breather? Sometimes if you suggest a simple over-the-counter bite guard to wear at night, that can help remind them to keep their mouth closed and they can breathe through their nasal passages, unless there's a significant ear, nose, and throat problem like chronic sinusitis or trauma or deviated septum, etc. You get the idea. The other thing is that sleep apnea is not just the overweight man's disease. It's surprising how often we find sleep apnea in clinic. Simple little physical exam finding. If I can pull this lid way too far up and away, and I can see the underside and there's inflammation under there, I'm going to ask about sleep apnea questions, quality of sleep, energy during the day. I need to catch that, because if I catch it, I can add 10 years onto your life if you treat it with CPAP, right? So these are all integrated things into eye care. The quality of your sleep improves and everything gets better. It's amazing how absolutely foundational sleep is. Dr. Adele?
Oh, thank you. And that is definitely true about sleep apnea. Everyone can hear me, I hope, now. Sorry about that. The compromised lid seal is another big one for me that, I honestly was probably not actively looking for. And so I was sometimes missing it because it can be so subtle sometimes, and it can change over your lifetime. As the bottom lid starts to lose some of its elasticity, a person that maybe didn't have compromised lid seal, in their 40s could have it in their 60s, just as that bottom lid starts to have a little bit more looseness to it. But then my son, who's 9 years old, also has a bit of compromised lid seal, and to the point of lagophthalmos in his case, because if I go in to check him at nighttime, I can, see his eye and have to sometimes shut it. So it's interesting when I talk to him, because, oftentimes children don't know how to describe something, but I will ask him, different things like, do his eyes feel sticky when he wakes up in the morning? Or, that's something that does seem to resonate with him. So you can definitely pull dry eye symptoms out of, the pediatric population or children for that matter, just by asking certain questions. So we do use some gel tears with him. I've had him try to sleep in the quartz that iEco has, but he's definitely not a fan of anything that's blocking light out. He's the kid that's sleeping with all the lights on still. So, but a big problem, because if you think about, if your eye is open and you're not producing tears during the time that you are asleep, and you're waking up with that dryness, just like you're waking up sleep deprived, from what Crystal was telling us, you're also going to be way behind your day. So now you go and you start working on the digital devices, you're not blinking, and it's just, you're fighting this uphill battle. So once we can identify that and start to treat that, it really can greatly benefit the whole way that we manage your symptoms with dry eye disease.
Mm-hmm. That's awesome. I just want to add one thing. There was a study that showed when you reduce the ambient light in your sleeping environment, the quality of your sleep improves and the rest improves. You need that pineal gland to reset your biological circadian rhythms. Super important for cortisol surges, every quality of sleep, concentration during the day, etc. So, I mean, he was a kid, but I'm sure he'll do better. But that's why I love the iEco masks, because you can get them opaque to help shut out some of the lights, so you don't have to spend thousands of dollars on blackout shades in your room. So it's just a very cost-effective way of protecting your cornea while you're sleeping. Patients will say that they wake up with much better feeling eyes. And the caveat is you have to clean it every single morning with a very simple soap. None of those fancy, perfumey, colored, dyed, no, just simple soap every single morning. Let it dry. It's a brilliant way of helping to restore some of that lid closure that's critical for our dry patients. The young patients, you'll often get a history of waking up at first light. That can be another way to catch incomplete lid seal. And it's an easy exam thing to do in the clinic with a muscle light. Your doctor can do that to check to see if that's an issue for you.
Super. Okay, I can't believe we only have 5 minutes, so I'm going to move us along here, and we're going to blow past. Hey guys, can you move to the slide that says environmental contributors, because there was a lot of questions about allergies, which came up earlier, but we were going to do one last pop-up poll, say that 10 times fast, about flare-ups, because often, especially when we work with a lot of Sjogren's patients, and there'll be some things in the environment that all of a sudden their symptoms will flare up, and it could be something for not just Sjogren's patients, but in general dry. I know for mine, when Santa Ana winds come up, it's like, ugh. So we were just curious to know, like, how often is that out there in the audience? Is that just something that occurs once or twice a year? And where are you on that spectrum? And so while you're answering that, if we can jump on into allergies. Dr. Odell, you want to share some stuff? You had some good thoughts on that one too. And it can be an open conversation, but certainly humidity. There are a lot of other contributors in environment that I think maybe the audience would like to hear more of. And then we'll take it to some Q&A and and what's up for the next episode.
The environment does have a lot of risk factors, for dry eye patients and really anybody. You're walking around with your eyes open to the world, during your waking hours, and there's one of the things that's helping to protect that is your tear film. It's constantly re-regulating what it's made of to try to help fight things off. You also, have your eyelids to help with blinking and your eyelashes to catch dust and allergens. But one thing I will say is that these things, low humidity, allergies, wind, those kind of environments will help to exacerbate or flare up dry eye disease. And sometimes they still will get misdiagnosed by the patient. A lot of times I have patients, and that's why the in-office allergy testing is so very helpful, because they are treating symptoms that they think are related to allergies, and they don't know what their formal allergies are too when it comes to the environment. So when patients are telling me about allergies, I'm always trying to be as specific as I can to learn, have they been to an allergist? Have we done allergy testing? What are they allergic to? Because, we can then do things like practice avoidance during certain times of year. And we can maybe target their allergy treatments for those times of year as well. But if they can't identify that, then I will work with an allergist or be able to do that allergy testing for the patient to figure out what exactly they are allergic to, because I feel like that's a big help to managing chronic dry eye disease. But a lot of times patients will just say, oh, my eyes feel X, Y, or Z. It must be my allergies. I find that a lot of times in mild dry eye, the patients that have yet to be diagnosed with dry eye, and they're just kind of going to the pharmacy or over the counter, to be finding products to self-medicate.
Yeah, I agree. We found an impact on environment on the poor air quality from all the forest fire smoke on the west. We see this dramatic increase in inflammatory biomarkers of dry eye patients during periods of poor air quality from all the forest fires. So that's another environmental load that we need to be mindful of and set our patients up for strategies to minimize the impact of that.
Super. We had we had a couple questions that were in this we haven't touched on yet too, that excessive tearing as a symptom. And would that be like allergies? Would that you want to explain why excessive tearing is a symptom of dry eye?
I'm just going to say one thing too about allergies and get to that, but itch and watering, right? Those are some of the key symptoms that I would think when a patient is talking about allergy. But there are different kind of itches, and sometimes an itch can actually be, a pain sense that's related to dry eye disease. One thing I ask patients is when your eye is itching, what are you doing? If you would rub it, does that give you relief? Because in a true allergy state, if you touch, you're just going to help release more histamine, and it's just going to create just kind of like that bug bite that you can't stop scratching. It really is hard to break the cycle of itching. A lot of times in blepharitis or even, dry eye disease, itching can be a symptom, and they will rub their eye and gain relief because they're, helping to spread tears or, blinking for that matter. So that it's important to figure that out. In allergy, you can definitely have a watering reflex. In dry eye, you can also have a watering reflex. So like earlier, how we mentioned, sometimes you are medicating for allergies when it's dry eye because these symptoms really do overlap. In dry eye, the excessive watering typically is more of a reflex mechanism that the body has. If the surface is dry, you're going to start to produce reflex tears because you don't want that surface to dry out.
To add on to that, Dr. Odell, the location of the itch. So when patients itch right there in the corner next to their nose, it's typically an allergy itch. Versus if they line with their fingernail, that might be more blepharitis. And if they're just going in with full fist, then it might just be dry eye, and they're trying to produce tears and pump that lacrimal gland.
I'm glad you said that, because the other thing that I do now is ask my patients if they do rub. We don't really encourage eye rubbing, but we know that patients do it sometimes. So I'll ask them if they do rub their eyes, and then I'll actually ask them to show me, so that I can get a feel for what does that look like. Is it right at the kind of base of their eyelash? And sometimes I have been really shocked to see how much damage a person's inflicting from their daily routine of rubbing their eyes.
Yeah, that's right. And mucus fishing, getting that little morning sand out of there that our allergy patients can have. You can actually, don't use a finger, no matter how recently you've washed it. Be really mindful. Go in there with a gentle Q-tip, maybe even a moist one, and gently roll it out, because we do see a lot of damage induced from the digging and pulling out the sand in the morning.
Great information. Oh my gosh, so we're already over, but I have a couple questions, if I could please. Just rosacea, this came up several times. What is the connection between ocular rosacea and dry eye? Anybody?
I love that topic.
Well, I figured that we'd leave that one for you, Dr. Perryman.
Rosacea is super interesting. Yes, there's huge correlations between rosacea and dry eye, meibomian gland dysfunction, but also gut dysfunction. So rosacea is associated not only with dry eye and blepharitis, but also all kinds of metabolic disorders, small intestinal bowel overgrowth, problems with anxiety, depression, cognitive fog. So rosacea is a loss of gut biodiversity. It's a commonly found feature of it. And so the last thing I want to do is prescribe doxycycline for you. That's going to make your gut biodiversity suffer even more. So we take a very holistic approach to the rosacea patient, talk about these awesome nutrition and gut health measures that Dr. Breimer covered so well, and Dr. Odell has spoken to, add the Whole30 diet, address rosacea local regionally as well, not only systemically, but local regionally. It's an integrated approach to get it back under control, and their whole body health improves when we do take that disciplined, intermingled, comprehensive approach.
Wonderful. Okay, so there was also 3 questions that came up about the connection between, I'm going to say this right because it's one that always is a tongue twister for me, fibromyalgia. Fibromyalgia.
Okay.
And the connection between that. So a lot of people wanted to know, is that there a direct correlation between having that and dry eye?
Yes.
I don't know. Yes. So, we have.
Yes.
We're over. Yes. So if you have it, be aware and see your doctor about dry eye. All right. We're 5 minutes over. I can't thank you enough, everybody out there. I know there's been a lot of questions. We're going to get to them. The beauty of this program is that it is a series. We're going to continue. And while there was a big urge to go to treatments and diagnosing and all this stuff during this episode, we really wanted to spend some valuable time kind of sharing just how big this conversation is relative to causes and symptoms. And I just echo Dr. Perriman's words of wisdom of saying, boy, there's so much we can do now. So have hope, have faith, just keep at it, because we're only getting stronger and more knowledgeable about how we can manage these symptoms. The next episode 2, is going to be November 10th, and we're excited. It's going to be a Tuesday evening, 5 p.m. Pacific Standard Time, and 8 p.m. Eastern Standard Time. We're going to kick it off with Dr. Now's fabulous presentation, then go into diagnostics, because what really matters in all of this is really getting proper diagnostics so that the doctor can take a look at you individually and see where you are, and that leads and the game path and the whole path towards treatment, whether it's in office or at home, that makes you as an individual feel better and have an improved quality of life. So I want to thank you very much. Thank you, doctors. You're amazing. I really appreciate your time and your knowledge and your commitment and your passion to helping dry eye patients. And I hope you enjoy the rest of your Saturday. Thank you. Hopefully see you on November 10th.
Thanks.